Welcome to another episode of the Grown and Greek podcast. Happy to be with you today. And this is going to be a great conversation, so cannot wait to dive into it. But let's first get out some housekeeping notes. Of course, you got to make sure that you are liking, subscribing, sharing, and commenting on the podcast on social media platforms and on YouTube. Please watch and tell a friend to tell a friend. And we would be greatly appreciative of that. But I want you to meet this episode's guest, who is a double board certified OB-GYN in maternal-fetal medicine specialist. She's a public speaker and patient advocate. She is an HBCU grad from Xavier University in Louisiana, where she held the title of Miss Xavier University and graduated with a BS in biology with honors. Girl is smart too. She obtained her dual MD degree and master in public health with a concentration in health systems management from Tulane University. Dr. Plenty completed her OB-GYN residency at the University of Mississippi. Now, after experiencing a difficult pregnancy, to increase her advocacy efforts, she launched Pregnancy Pearls with Dr. Plenty, which is a blog and podcast where she created to help patients advocate for themselves, providing pre and post conception advice and education regarding complications in pregnancy. Please welcome to the Grown and Greek podcast, my soror, Dr. Nicole Lee Plenty. Hello, my dear.
Hello. Thank you so much for having me. I am really excited. It's always nice to talk to a fellow soror that's doing her thing. So.
Well, we do our part, but I'm not doing it like you. You are like out here saving lives, and I'm just trying to tell people about it. You know?
Well, you're doing a good job. You know, using your platform for something positive is always good, and it's always appreciated for sure.
Well, I had a little trouble saying maternal-fetal at the beginning, introducing what you do every day. So let's dive in there and kind of summarize what a day in the life of Dr. Plenty looks like.
So a lot of people have trouble saying maternal-fetal. It's a tongue. It gets you tongue-tied, doesn't it?
A little bit.
Just a little bit. So, I mean, it's abbreviated as MFM. It used to be called perinatology, which is obstetrics. So I'm an OB-GYN, but I now concentrate on just high-risk obstetrical patients. So I take care of patients that are high risk. And when people hear, oh, I'm high risk, they're like, oh, I'm high risk. I'm like, it's almost better to be labeled high risk so someone else is watching you, right? When we hear about poor outcomes and, you know, people dying in pregnancy, usually they're not followed by a maternal fetal medicine specialist. So we're the people that take care of those high risk patients, that lay out a delivery plan of like when they need to deliver, how often they need to be seen. So for me, I see all pregnant patients. So day in the life of me, like this week I'm on call. I went to the hospital this morning. I saw patients in the ICU and patients that are on labor and delivery that may have complications during their pregnancy. Their water may have broken early. They may have had a heart attack in pregnancy. They may be septic. I'm seeing those patients. Then I go to the office. So I went to the office today. I had a half a day of patients where I saw, you know, patients that just do, you know, consults. So they come, they have not had anything to happen, but they have risk factors for things to happen. So that's people that have advanced maternal age. So if you're over 34, you are high risk just at baseline, right? Because there's a higher risk of having a baby that's smaller. There's a higher risk of hypertensive disorders of pregnancy. There's a higher risk of your baby having some type of structural problem. So we do ultrasounds to look at those babies to make sure that those babies are structurally normal. And there's also a high risk of you having a preterm delivery or needing a C-section. So I will do consults on people that don't have complications right now, but may have high risk, maybe at higher risk for complications. We do ultrasounds. I read those ultrasounds, and then we make a plan for the pregnancy. And then usually if I'm on call, I may have to go back to the hospital. But if I'm not on call, I will just be in clinic doing those consults and reading ultrasounds. So that is pretty much what a maternal fetal medicine doctor does. It's a combination of OB, like being an OB-GYN, being a radiologist because we read a lot of ultrasounds, and being an intensivist because we take care of critical care patients in the ICU.
What's the best part of it? Best part of the job?
I love it all. Like,
Okay.
I think I have the best job in the world. It's one of the most flexible jobs in medicine, right? So if you have a surgeon who breaks their arm and they can't operate, well, they don't have a job anymore, right? You have an internal medicine doctor that doesn't want to see patients in clinic and they want to do procedures. Well, they got to go back to training to do that. MFM is a field that if I want to do surgical intervention, I can do surgeries. I can do intrauterine surgeries and intrauterine blood transfusions and intrauterine shunts on babies before they're born. I could do all consultation only in clinic. I could be an intensivist and do all hospital work. Or I can just read ultrasound. So it is a very versatile field within obstetrics. Obviously, it takes a little bit more training because you have to do your 4 years of medical school and then 4 years of residency, and then you have to do 3 more years of fellowship to do the field. But I love it. It's very rewarding for me when I have patients that may have had a poor outcome before, and I can safely get them through the pregnancy this time and give them some peace of mind to say, this is the plan. You're not dying. Your baby's not dying. This is what we're going to do. So that's very rewarding for me. It's also rewarding, even if I have a bad, have a bad diagnosis, making sure that people know upfront what's going on and we get a plan in place. Because I think that people, some doctors don't want to give bad news. Unfortunately, I have to give bad news sometimes. I'm dealing with patients that have risk factors for getting bad news, but being able to relay that bad news in such a way that makes them understand what's going on with their child or in their body, and also formulating the best possible plan to turn a really bad situation into maybe not so bad for that patient. And I've had patients that have been so thankful for me just taking the time to explain things, and I'm like apologizing because I have to tell them this horrible news, and they're like, well, at least we know. We know up front.
Mhm.
We can process the information. We have a plan with how we want to go forward, as opposed to finding something out once the baby is here.
Mhm.
It's a difference finding out in the pregnancy and being prepared versus finding out when the baby's here and now things are rush emergency.
I have so many questions. I'm trying to think where to start because I think a lot of them are important and hopefully touch on some of the things that you said. But one thing that I guess is like really concerning with pregnancy, high risk pregnancies, and just maternal, especially with us, Black
Yeah.
maternal health. Number one, why is this so common now? With that's the first question, and then secondly, what can we do about it? You're stepping in, being a voice and a face,
Mhm.
but what else can we do about it to make people more aware, more women more aware, to number one, prepare themselves, but then to know where to look for this help, because it's so not available. It
Well,
seems, let me
it
say
it's not even that it seems, it's true,
that.
right?
Okay.
Um, you know, why is it so common that Black and brown women are having higher risk pregnancies? Um, One, the teenage pregnancy rate is down. That's a good thing, right? Because teen pregnancies do have a higher risk of complications and high risk of preterm deliveries, but they don't have the higher risk of cardiovascular disease and things like that people have when they're older. Black and brown women are the most educated women now in the world, right? And because of that, we delay childbirth later. We're older when we have children. And because with age comes things like more weight that we put on us, we may have underlying vascular disease or underlying high blood pressure that we just don't know about, right? And pregnancy, your blood volume doubles. So you might have been bebopping around, your blood pressure is like 130s over 80s, not that big of a deal, but you throw pregnancy on top of that, your blood volume doubles, your heart has to work twice as hard, your kidneys have to work twice as hard to filter twice as much blood. And it unmasks things, right? Now you have high blood pressure you didn't know about. You're getting diagnosed at 12, 13, 14 weeks. That's not because of the pregnancy. That was underlying, that was there. You
Wow.
just didn't know about it, right? And so we're having to put people on antihypertensives. Now, you know us. Sometimes it takes an act of Jesus for us to start some medicines. We want to do it ourselves, right? And so people get referred to me at 20 weeks because they have high blood pressure. They say, I've never had high blood pressure. I'm like, let me explain to you how this works. If you have elevated blood pressure before 20 weeks, you technically have something underlying. It doesn't mean you need to be on medicine for the rest of your life, but it does mean that our goal is to treat you to 120/80. Not for you to reduce your salt. Salt did not cause this. Not for you to reduce your salt, not for you to change your diet, not for you to try to lose weight. We don't want you losing weight in pregnancy. You need to start the medicine to lower your blood pressure early, okay? And you need to be followed closely. So one, age. Age has a lot to do with it. Two, weight, okay? We are heavier and we are more educated, which means that sometimes we are delaying childbirth later. So there's more people now that are pregnant in their 40s than that are pregnant in their 20s. That's just fact. So you have a lot of people that are high risk now because of that. And with being high risk, there are complications that can happen, right? If people are high risk but treated as low risk, meaning you're getting your dating ultrasound, you get your anatomy ultrasound, and you might get one other ultrasound at the end of the pregnancy, the diagnosis may be missed. You're getting routine prenatal care by a mid-level provider, which mid-level providers are great. My mid-level provider is amazing, right? I have a nurse midwife. She works in conjunction with us. She's very good, right? But all mid-levels are not the same. And in their defense, they're not high-risk providers. They're low-risk providers, right? Should be taking care of people with pretty much normal BMIs. They, in their 20s, early 30s that are at low risk for complications. They should not be taking care of high risk for complications. Why? Because they're going through their checklist and they're doing it all. But when, Sarah Ann comes in and says that she has a headache and her blood pressure is right at that 140/90 mark, they may be sending her home and telling her to take Tylenol versus doing some lab work and starting medication.
Ooh.
So a lot of it is, lack of high risk providers, whether that's an actual OB-GYN, mid-level providers having to operate honestly outside of their scope because it's not their fault that they're not recognizing some of these high risk signs. That's not what they're there for. They're there to take care of low risk patients. And then there's just not enough providers. I'm not sure where you are, but I'm in Georgia. I'm in Atlanta. And in Georgia, the state of Georgia,
I'm Alabama, so it's just
so you're similar.
Yes.
There are 82 counties that have no OB-GYN. I'm not talking about a maternal-fetal medicine doctor. I'm talking about an OB-GYN, okay?
Are you serious?
I'm serious. So you're having patients that have to drive to get the obstetrical care. You're having lower risk providers that's having to step up and take care of some of the highest risk patients. And then you also have other people, family medicine doctors that have to provide this care, and they do a great job, but they're not for high risk people that are at high risk for having babies with anomalies or needing a C-section and things like that. Okay. So there aren't a lot of us. So what do you do to advocate for yourself? One, you have to have a come to Jesus with yourself and say, I'm high risk, right? If you're over 35, if your BMI is over 30, then you need to say, hey, shouldn't I be seeing a high risk provider? That may mean if you're in one of those rural areas, you might have to drive 30, 40 minutes to see a high risk provider. Okay. If people can't, if you're getting ultrasound and they can't tell you everything's normal, ask, can I have a second opinion? Can I go to someone else that can make sure my baby is okay? If someone's telling you your baby is small and there's nobody looking at your baby every week, you need to say, is my baby need to be looked at every week? Now, mind you, we're having this conversation now, but patients don't know necessarily to ask that. So some of this has to be on the provider to recognize who's high risk and who's not. And I've seen so many providers that'll say, patient offered a referral to OB services or patient offered an MFM referral. Patient doesn't want to go right now. What? Like, you don't have a choice. You need to tell them this is what's recommended. If they refuse that, then you document what's recommended. But I'm going to let your listeners know, don't refuse a second opinion. Don't refuse a consult. Go, ask your questions. And if you don't need to go back, that's one thing. But once you put, from a medical legal standpoint, because I do a lot of medical legal review, you have a poor outcome and you refused a referral, then it looks like you just didn't want, you didn't want the evaluation, right?
Mm-hmm.
So then there's not a lot of leg to stand on depending on what the outcome is. So I always tell patients, if they ask you to drive, even if you feel like you can't get there, do the appointment and then tell them, hey, I have transportation issues. So they can work on making sure you get some transportation, because that's our job to do. As a high risk specialist, I have nurse navigators and all these people that can help get somebody from point A to point B that a patient may not know about, right? Even if they're underinsured or uninsured, there are resources that we can put in place to say, hey, it's going to take her an hour and a half to get here. What resources can we do to get her a lift right here and back if she does not have insurance? So making sure you're asking questions. I tell people, take a notebook with you, write it down.
Mm-hmm.
Write everything down, who you talk to, all the questions you ask, and write the answers down. Come with your questions. I recommend anybody high risk have a doula, because I think they
Really?
make a difference.
Okay.
I do. I am pro doula. I'm pro
Okay.
doula because I feel like sometimes people can get very almost like anxious in the doctor's office. They don't know what to ask, or when somebody's explaining something that may be complicated, especially if we're going over a plan for your whole pregnancy, they'll freeze up. They don't know what to ask, and they'll say, you have any questions? No. I said, okay, are you sure you don't have any questions? And some people are not going to ask you if you're sure. If you say you don't have any questions, they'll be like, okay, great. Let me walk you to the front and get you out of here, right? Because you don't have any questions, right? And nowadays, the way insurance is set up, doctors are paid by time, right? So they can't waste your time. And so if a patient complains that, hey, this doctor kept me longer and I shouldn't pay this bill, then they have to justify why they kept you longer. So they shouldn't be really probing you for questions. If you don't have any questions, then move on, right? So some people are not going to ask you 2 and 3 times if you have any questions. A doula is very good at knowing what questions to ask and what questions, they can answer themselves. So patients that come with doulas, it's like a discussion, right? Your doula should come with you to your appointment. A lot of health systems will provide doulas for free. Mine does, if you want a doula. And I do recommend, if you have some complications, you have a doula. Somebody that can remind you of what I said. The most common consult I get is babies that are small, so fetal growth restriction. Those small babies have increased risk of stillbirth, so they have to be monitored every week once we diagnose it. And the doula is very good at saying, Dr. Plenty didn't say anything was wrong. Your baby's just small right now. They're monitoring to make sure. So it's that level of reassurance to give the patient when I'm not around. It's making sure the patient remembers their appointments and goes to their appointments. And if that patient has questions that they may be in conversation with their doula about, the doula is very good at saying, hey, you asked me about this pelvic pain yesterday. You want to go ahead and ask her for her opinion? They're very good at pulling that information out of patients so that patients understand what's going on. And honestly, when you come with, even if you don't have a doula, come with somebody to your appointment. And I'm not saying that you're treated differently, but they treat you differently. Okay.
Yeah, I mean, you have an accountability like
It's
person.
2 people listening, not just one.
Right.
Come with somebody that can hold that doctor accountable. And doctors do spend more time when there's another person in the room. For sure.
That's like having your mama almost in there with you to say XYZ, or she did this yesterday. What does this mean, and what should she do about this? Because I know she's not going to mention it or whatever.
Yeah.
But I know you were mentioning, and it's true. Black and brown women delay pregnancy and things like that. And I know we're not talking about like fertility, which is I guess a different conversation. But in terms of these high risk situations that women can put themselves in, what would you say like the perfect scenario would be, in terms of planning a pregnancy for, and maybe that's a loaded question, I don't know, but in terms of planning a pregnancy to prevent as much as possible issues that may arise, because we don't know what things are going to look like in terms of maternal health in the coming years. We don't know what resources are available in the coming years, and we might not have none. Who knows? You know what I mean? But I think it's important to have those conversations now. So a 10-year trajectory, if that's what it looks like, what does that need to What would you say to that?
Yeah, people aren't going to like this answer because I remember when I learned of it in med school, I didn't like it, right?
Mhm.
The perfect age to have a baby is 24 to 27. That is the perfect age.
Mm.
That is the height of your fertility. That's when all your, female organs are, developed. That's before you start your egg count starts drastically decrease. 24 to 27 is the perfect age to have a baby. But listen, if you are a Black educated woman, you finish an undergrad 22. If you go straight through, which some people don't, and you go to, law school, med school, you get a PhD, you get a master's. Now you're talking about 24 to 26 with those higher level degrees. And we do have the most higher level degrees, Black and brown educated women. And if you're Greek, you definitely have the most
Mhm.
education. And so now you're looking up and you've been grinding. You are not worried about him. You trying to get this paper. You're trying to make sure you get this degree. And so you look up, you're 26 and you don't have anybody. So now you're dating, right? And
Mhm.
you may be dating a couple years. We want to get married first before we have our first baby. We can help it, right? Now you look up and you're 30. And that's still okay, right? Your egg count is still good. Your egg count doesn't start dropping really. Once you hit 35, that's when it starts to get a little sticky, right? 35 is when people start to have, I'm trying a couple more months. It's harder for me to get pregnant. That's when your egg count starts to decline. Now, once you hit 39, it really starts to decline. And once you hit 40, it drastically declines after 40. So I always tell people, if you're professional and you don't have a man, or you don't want to have kids right now, right? Because the person I had my child at 37.
Mm.
The 27-year-old me didn't even want kids, right? The 37-year-old me was ready to have a baby, right? I'm a completely different person now. I'm in my 40s than I was when I was in my 20s or even my 30s, right? If you're not sure and you have the finances, freeze your eggs. Once you hit 35, just go ahead and freeze your eggs so that you can make decisions. Now, I would not tell you to freeze embryos unless you know for a fact who you want to have kids with, right? Because then you get into these situations where you are serious about him, y'all not ready to have kids, you frozen embryos, which are your egg and his sperm fertilizing, you know, fertilizing the egg, and you're freezing that at the blastocyst stage, or so at a couple cell stage. And let's say y'all break up. This happens all the time. You break up and he says you can't use those embryos anymore, but you don't have any eggs frozen. And now you're 40 and your follicle count is super low and they're telling you need IVF anyway. So then you're in a situation where you're like, am I going to fight him in court to be able to use these embryos? And even if he gives you permission to use the embryos, are you really going to have a baby by somebody you don't want to have anything to do with? So you have those questions. I always tell people, if you're married or you're in a very committed relationship, freeze the embryo because the embryos do have a higher success rate than the eggs. If you are not married, you're single, freeze the eggs and then you can get them fertilized later on. And if you don't need the eggs, then you just don't need the eggs, right? An egg is not a person. No matter what law you follow, an egg is not a person. An embryo gets you sticky, right? Because in Alabama, you can't discard the embryos. You have to keep them or donate them, okay?
Mhm.
Because they're considered humans. Same thing in a lot of other states, okay? In Texas, you can't discard them. So that's why some people aren't getting IVF done in Alabama or in Texas or in a lot of these conservative states because they're like, well, what am I going to do with these embryos? I got 4 embryos. I got to, pay the $2,000 a year storage fee for life, so it's a lot of ethical things that can go into that. Or you transfer them to another state and then you can donate them to science. So there's a lot of things that go into whether or not you will, freeze embryos, but you're freezing eggs is different. You waste an egg every month when you ovulate and you don't get pregnant, right? So it's just that you're getting that egg taken out and freezing it so you can have that egg for later because your egg count goes down, down, down. So optimal timing before 30, but less than 35 would be best. It gets harder. Not saying you can't get pregnant after that. Obviously I did, but it does get harder to get pregnant the older you are with the most struggle once you hit age 40. And then you also have to realize, even if you get pregnant, there is a higher risk of having babies with chromosome abnormalities. The older you are, the more likely you are to have a baby with Down syndrome or some other chromosomal abnormality. And at age 42, that risk is 1 in 50. No.
Wow.
Yeah.
Okay.
So it's pretty high.
Wow. Wow. You have your podcast, and one of the reading, about you, one of the reasons you started it is to help to get the word out about some of these disparities and bust myths and just educate people about it. But why was that so important to you? And going on your personal journey, how much of it played a factor in you wanting to participate in these ongoing conversations?
Well, I think that people don't talk enough about anything that's going on with their lives, right? Not just pregnancy. Like, we don't talk. Like, I think Black people don't talk enough about finances within their family.
Oh
They don't talk
God,
enough
you're
about
right.
family in general. Somebody
Mhm.
died and you find out you got 4 other cousins. You're like, where they come from? We don't talk enough about things. We put up this sort of wall and we make things seem like it's perfect, right? I'm happy, it's perfect, I'm healthy. And then you find out this person has like fibroids and heart disease and all these things. And you find out that everybody in your family has fibroids, but nobody told you. So you could have, been looking for this and getting these fibroids removed before you have fertility issues. So we don't talk about it. But when you talk about things that are life and death, we have to talk about it. And once I got pregnant, this is what I do. I was able to call up my troops, right? So I had a high risk pregnancy. I knew I was advanced maternal age. I had fibroids. I had a miscarriage. That's how I found out I had fibroids because I didn't have any symptoms. I had a miscarriage.
Wow.
A year later, I got pregnant with my son. At 10 weeks, I had a blood clot in my leg, a really big one, from basically the vessel at my hip, which is the iliac vein, all the way down the femoral vein, all the way past my knee. And I had 5 pulmonary emboli, which are blood clots in your lungs. So you probably heard of Serena Williams.
What, Nicole?
Yes. And all this was caused by fibroids. Now, my fibroids were small. Okay. When I had the miscarriage the first time, biggest fibroid, 3 centimeters. And my OB, who's a soror and who's one of my best friends, said, listen, I don't know if we should take the fibroids out or not. And I said, well, rule of thumb, if they're not bothering you, don't bother them. If I have another miscarriage, then I'll talk to you about getting the fibroids removed because I really didn't want a surgery. The next pregnancy, the fibroids quadrupled in size. So the one on the backside of my uterus was 8 or 9 centimeters, which caused compression of the vessel. And that is what caused me to have this big blood clot. Now that I'm not pregnant, it's gone back to being nothing. Barely see them. But in the pregnancy, I had, this, big blood clot and could barely breathe. And I was able to call up my OB and say, hey girl, can you order a lower extremity Doppler on me? Because I'm pretty sure I have a DVT. She said, you sure? I'm like, yep, I'm positive. And I was able to pick my hematologist that I want to treat me, handpick my pulmonologist, call up the vascular surgeon myself, and even pick the nurses that were taking care of me, right? I had very good care, but I was very knowledgeable about what was going on because it was what I do, right? And I realized that most people can't do that. Most people are not diagnosing themselves. They're not handpicking their OB and their specialist. They're not able to get in with a specialist as quickly as I was able to get in by just texting and saying, hey, this is what I have going on. I need a follow-up in a week. They started me on Lovenox. People can't do that. And so I really felt at that point that people need access and people need conversations and people need to talk about it and they need to know what questions they need to ask their doctor. So that was really a big push for me starting initially the YouTube channel. It's initially a YouTube channel. And then Ken said, let's turn it and make this a podcast. So that's how it became a podcast because that can reach a bigger audience of people,
Right.
And that sort of kind of exists forever in La La Land where people can go back and listen to those episodes and get advice. And I still have people now because we're, between seasons at this point that will text me and ask me questions about stuff I said in season 1 or season 2 because people are getting pregnant. They're looking for information and they're looking for resources. And social media is a great thing, but it also can have people that don't have knowledge giving out information randomly. So they're giving out their own personal advice with no data behind it. So I really do think that people that are in their professional realm, we should really take the time to give our own professional advice out. So as a doctor, I should give my own professional advice out so that people can have some tangible information that they can rely on, as opposed to looking at a TikToker that's just telling about their one pregnancy journey, because every pregnancy journey is a little bit different. If you have a background in finance, you should be on social media giving out these tips on finance instead of somebody just telling you how they feel like they made some money on stocks with no education behind it. So that was my push. I wanted to make sure people had the information, knew what to ask. And I also had a cousin that passed away from complications of pregnancy, which is why I became an OB-GYN in the first place. Before, I wanted to be an attorney. I was like, I want to be an attorney. I want to be a senator. And when she died when I was in college, I switched everything, right? Because I wanted the answers and I wanted to know, why this happened and how did this happen to somebody 23, a former cheerleader, thin, no medical problems. How did this happen?
Oh my goodness.
So that was my push to go into OB, but it was just eye-opening when it could happen to me. I do this,
Right.
I know all the signs, and I still have complications in pregnancy.
Well, I can, like, from my own personal journey, I've had the whole fibroid journey struggle. Yeah, it's exhaustive, exhausting. But a lot of it was, like you said, there was no information. Like, you just started hurting or you started feeling a certain way, and then you you go to the doctor, you go to your annuals and things like that. And like you were saying, it's I guess it's a little comforting because I'm not the only one that has experienced that. But at the same time, there are so many that have experienced issues and so many that don't know the questions to ask. But, from on a personal note, it wasn't until I started seeing doctors and physicians that looked like me that I got the answers and the care that I needed. And just real conversations, to say, girl, look, you need to do XYZ, or you need to start thinking about XYZ, or you need to, maybe think about this. Oh, well, we don't necessarily have to do surgery, or we don't necessarily have to go this route or whatever. When I've seen other, doctors who immediately want to eliminate everything, and that's such a hard place to be when all you want to do is get the answers that you need, so you can make the informed decisions, whether they're, life-changing in a bad way or life-changing in a good way. And so, I just, want to applaud you, celebrate you for what you do. And I have listened, I was telling Ken, I've listened to both of your podcasts, but I've listened to Pregnancy Pearls, and, some of the nuggets and things that you've dropped on there. And it's universal, it's not just solely based on pregnancy information and things like that. You talk about general health things that we should, advocate for ourselves when we are talking about just women's health in general. But, so I want to celebrate that and definitely want to shed a light on, the podcast and the information, the jewels and stuff that you drop all the time. But being a member of the Divine Nine and being in the medical field and being a leader in the medical field, and you mentioned that you see another soror who's your doctor. The doctors that I see are actually deltas, which is wild. They're within the Divine Nine. But what are you seeing, and how would you advocate for us to turn internally to the D9 to find levels of care that we need in order to, get to those optimum places of health? Because you're here. They're, the deltas that are my doctors, they're there. Can you advocate and, say something for, us turning, like I said, internally to seek the types of care that we need?
Yeah, I do think, one, most of the time, if you're involved in a chapter, I see it all the time. Well, people will send a note and say, hey, I'm looking for and
Yeah.
OB-GYN,
Yeah.
does anybody have an OB-GYN in this area? And I will automatically say, these are the OBs that you should go to. And they're almost always in the D9, right?
That's
Because
crazy though. Yeah.
we're involved, right?
Yeah.
Like there are a lot of, professionals that are Greek.
Hmm.
You have to maintain a certain GPA to be Greek. You pretty much have to be pretty involved. You have to have something on your resume to get in there, whether that's in your grad chapter or in undergrad. You doing something to get the attention to be invited to these organizations or get the vote into these organizations. So it's not uncommon that there's a lot of doctors in the D9. Now there are some doctors that aren't Greek, but that's in Atlanta. It's not. There's a lot of us. There's a lot in the D9, and we do refer internally to each other, and even the people that aren't D9, I am more likely to refer to another physician of color than I am to one that's not of color, especially if I think that my patients are going to have a good experience with them, right? They can be real with them. They're not going to feel rushed. They're going to get thorough care. They're going to be, follow evidence-based guidelines. And I will say that most, sorors and, D9 sorors, we are D9 and we're able to juggle at that level to excel professionally. So we can we can manage and juggle probably better than the average other person that's not in the
Hmm.
D9 because we do a lot of stuff, right? And so because of that, we tend to be more investigative, right? We tend to read articles, we tend to question things, we tend to interrogate things a lot more thoroughly than people that may not be juggling as much. So I never refer someone to someone that's in the D9 that my patient had come back and said, I had a horrible experience with them. Now I've had some people that aren't in the D9 that my patients have come back and said, I feel like I couldn't talk to them, or they weren't down to earth, or they weren't X, Y, and Z. Most people in the D9 are going to be a little bit more relatable. We're going to be a little bit more down to earth, but we also, because we've had to operate at such a high level and juggle so many things, we up on game. We know how we have to be at that, maintain excellence, right? And everything we do, you know how AKAs are.
Hmm.
It's like, you got to look good. You got to put your stuff together. You got to make sure you're prepared. That's how we come on the job as well. And that has never failed me. Now I've had people that aren't on D9 that scraping by, and patients come back and report back that they didn't have the best experience, but never a doctor in the D9. So
Mm.
go ahead and find you a D9 doctor.
That says it all right there. Because I mean, literally, my life changed when I started seeing doctors that were D9 doctors. And so, anytime I can refer, like you say, or, say, go see this person or go see this person, it's amazing that they are literally like D9 members, and it doesn't matter, across the
Yeah.
board. But, that level of excellence is what we, how we represent.
Yeah.
So, thank you for saying that. So you also work with a few boards, and you're advocating for different policy positioning and things like that. What are some of the things that you are working on, some of the policy changes and things like that you are working on that will affect people in the field and in medicine and stuff
Yep.
that are important?
So I just came off the national board for the American College of OB-GYNs. I'm still an advisor to the CEO for the American College of OB-GYNs. And of course, the biggest thing that we're working for is anything that's women's health and women's health research. It's gotten cut. The new administration, they can't care about women.
Mm-hmm.
When you talk about the amount of access to care issues that we have been battling, it's ridiculous. And we're not just talking about abortion access, we're talking about care, right? Women that's been, there's a woman in Tennessee that was denied care because she was unmarried.
Yeah.
What year are we in? Are we back in the 1950s? So those are the kind of things that we are fighting. Access to care, of course, access to reproductive care, which includes abortion care, fertility care, and making sure insurance covers the IVF treatments and things like that we need. That is a huge push. And then within the American Medical Association, it's increasing Medicaid funding. This big, beautiful bill is going to, it prides itself in saying, oh, well, it's giving more money back to the taxpayers because you're paying less in taxes. But 12 million people are going to be cut from Medicaid. The fact that you have to have, work requirements to have Medicaid it's, I can see how it's good, but it shouldn't be universal, right? This shouldn't be the blanket end all be all to say every 6 months we're going to look and see if you have worked, on average 40 to 60 hours. That's mind boggling, without those exceptions. And of course, exceptions will come over time, but there'll be somebody that has to sue or somebody that has to fight to get that exception. And then the exception will be in place. So it's almost like we're having to work backwards to be able to get the coverage. Hospitals will close if patients don't have access to Medicaid, right? Because now people are going to start using the ER for their primary care. Anytime they have an issue, go to the ER. They're not going to be able to pay their ER bill because they don't have Medicaid. They don't have any insurance. So what's going to have to happen? The hospital systems are going to have to eat up the cost. Now 50%, almost 50% of Medicaid is going to be funded from the states. The states can't afford what we have now. So I am afraid that access to prenatal care will definitely drop. And people are going to have no prenatal care and then just come and deliver. And then access to life care will be limited because we're going to have to use the ERs for care because people are not going to be able to schedule appointments without Medicaid or Medicare. So those are the things that we're fighting. Medicaid and Medicare coverage, Medicaid reimbursement are things that I feel like we've been fighting forever. But then when that big, beautiful bill hit, it was on a whole new level.
Mm-hmm. We're in a, I don't even know the word to describe, where we are. It's
an interesting.
I want to use a, I want to use a not so nice word, but I won't. What do we do? Like, high level solutions that you would say.
Things take time, right? This is going to take time, and we foresee a lot of lawsuits coming, right? That'll stop some of these things from going into place. That's what happened with the fertility restrictions, right? There was a lot of lawsuits and, limitations to, abortive care without any exceptions, right? Lawsuits came out which stopped the laws from going into place. So we'll see a lot of that, and hopefully that'll be enough to sort of push us further out until we get to another administration. Mm-hmm. But people need to be vocal, People need to make sure you're voting in your midterm elections. The Senate and Congress, they're the people that's allowing and empowering the administration to be able to operate blindly. It's not just people say, oh, Trump did this. I'm like, no, Congress and the Senate have a lot to do with that, right? Because they're the people that can put a stop to that. There are, different levels of government for a reason. And when we only vote for the presidency and we just let everybody else just sort of kind of slide in, it sort of allows the presidency to go unchecked. So there's no checks and balances right now. So the easiest thing people can do is vote in every single election, in every one of them. And, you pick the lesser of the evils. And people are like, I didn't vote for Kamala because she didn't relate to us. I'm like, but you voted for the other person. Mm-hmm. And he didn't relate to you. I don't understand. So people, we tend to criticize our own more than we criticize the majority. And we got to stop that. Mm-hmm. And that's at a lot of different levels, not just at the level of the presidency, but you'll see it in the professional setting as well. I see it all the time in the hospital. This doctor is Black. She's on probation because she had an attitude problem and people feel like they can't relate to it, right? But you got this surgeon over here throwing instruments across the wall and he's not on probation. What is the deal? So it's a different stand. We have a different standard for each other, and maybe not us Greeks, but Black and brown people in general. It's like a different standard. And you can't tell me otherwise, because we would never have voted this person into office. Now, we're the 92%. We did our jobs, mm-hmm. but everybody else didn't do their job, and everybody has an excuse as to why they didn't do it. And now we're looking around and realizing, oh my God, this is all that's happening, and we're not even a year in. So the best thing is vote.
Yeah, it's and it's crazy because if you're a woman, like, for the life of me, I just don't understand why that's not at the forefront of your mind and your decision making. I mean, we already have a hard enough time as it is, with all the stuff we got to go through monthly. I mean, my God. But that's not the straw that breaks the camel's back. It's just, being able to have access to things, get answers we need. And then on top of it, if there is access, to be able to afford it, and all of those, opportunities are going to be gone because of what we're experiencing now. And so, I just don't understand. Like, I don't understand how we got here, number one. And then I just don't understand, why people can't see the forest for the trees to know, what you were saying.
Just some of the
women's health is a real issue.
Yeah, we should all women, not just Black women, because Black women do what we have to do.
Yeah.
But all of us should have taken a stand. I'm like, how do we, it's mind blowing to even think about it. Some of the, education is going to be drastically affected. Obviously, with the Department of Education just literally cut up.
Yeah.
Hey, get rid of the Department of Education. It happened. So with the Department of Education gone, now student loans capped at $200,000 for undergrad, grad school, for everything. $200,000, most you can borrow. That's going to hurt a lot of people. That's going to hurt a lot of people that are planning to become doctors or lawyers or professional. That's going to hurt a lot of low income people that may depend on student loans. And we're going to have to not sit back. Write your congressmen, write your senators. Bevo, you go to Google them, Chat GPT them. They'll tell you what to write and email it in. So people can know that you're not silently sitting by while all this happens. That leaves the elected officials more accountable. Okay, They didn't say, well, nobody's complaining in my district. Well, yeah, we are. We are complaining. We wrote you a letter on this day and we said X, Y, and Z, and you still voted for it. So we got to vote you out.
Right.
So just, be vocal. And, it may not seem like a lot to send a letter to your congressman, but it's a lot. Like, that kind of stuff adds up. And when people are going to lobby and they know that letters have been sent from the district, it makes it easier to say, hey, there were 50 letters that were sent from this district about this one issue. What are you doing to address it? To leave some accountability there. But outside of politics, get you an insurance plan, right? If you know that you're not going to be eligible during open enrollment season coming up in October, get you one of these insurance plans, even if it's a high deductible plan. Because what happens is you get hospitalized, it'll bankrupt you. It'll bankrupt you. And now this Trump administration is saying that, the Biden administration said the hospital bills, we're not going to count that, right? This Trump administration said, we are going to count that. We're going to make you pay that back. We're going to start garnishing your wages because of this. So get you a bill, because at least even if you have a $5,000 deductible bill, owing $5,000 is way better than owing $150,000 because you don't have any insurance. So, because that'll bankrupt you. So get an affordable marketplace, even insurance plan, just in case you have to be hospitalized for some reason, that you're not going to be catastrophically, bankrupt. You have some type of coverage.
That's good information. Now you're a mom, you're a physician, you're on call, so I hope you won't get a call.
I've been looking at my phone.
Hope you won't get a ping while we're talking. But how do you balance it all? How do you stay grounded, Nicole?
I am very good at turning things on or off. Now, if you ask people in my job, because I'm division director, they'll say, she's working all the time. She's always here. But I'm not, right? I go in early because when I'm home, because I have a 6-year-old son, when I'm home, I'm home. I like to be completely off. I like to give my undivided attention to him. If I have an emergency call, which honestly I hardly ever get, then I'll answer and give people guidance. But for the most part, I round early. Like, I'm out of my house by, 6:15, 6:30. I'm going to the hospital around, because I never want anybody waiting on me, right? If you're waiting to deliver somebody based on my opinion, you're not going to wait on me. I'm going to tell you what my opinion is. So I don't like people to wait, right? You're trying to figure out if the patient can go home or not. I'm going to be there early, so you're not waiting on me till 12, 1 o'clock, 2, 3 o'clock. I like to round early and get it over with. I tend to check emails. So as a division director, I have set hours and I go by that. People know if you want an answer from me, you send me a text message, I get back to you real fast. You send me an email, I'm only checking my email on Monday mornings, Wednesday mornings, and maybe Friday if I'm working. I do not check my email every day. I don't do it because you can get inundated with emails. You're sending emails back and forth, then they send a reply. No. If you need an answer, call me or text me. I have 48 hours to reply. I'm going to tell you, these are the days I have hours and these are the days I'm going to reply. I'm very accessible, but I'm very strategic about my time. And I'm also very strategic about when I'm going on meetings and how soon you can play. You can't put a meeting on my schedule the day before and expect me to come. Mm-hmm. Absolutely. I will decline a meeting in a second. I need 72 hours because I want to know what the meeting's about. I need to know what the agenda is for the meeting, because you're not going to waste my time talking in circles on a meeting that could have been an email. So I need to know. And if I don't need to be there based on the agenda, I'll say, hey, I'm not going to be present. Here's where I will weigh in on this agenda. Period. So I try to keep a balance. I try to turn work off completely when I'm off. The exception is when I'm on call, I'm a lot more accessible. I try to make my schedule in such a way that I'm not missing my son's big things. He knows he's 6. So he has different things on different days. He has golf on Mondays after school. He has taekwondo on Tuesdays and Thursdays after school. Further after school, like 5 o'clock. Then he has Kumon learning that he does on Wednesdays, is where he is now. And then he does that on Saturday mornings as well. So he knows, like, mommy's not going to take you to Kumon. Granted, Lisa's going to take you to Kumon. Mommy is going to make your taekwondo one day a week. I'm not going to make both days. So he knows what I'm going to make and what I'm not going to make. And I'm very transparent with him about that because I don't want him to be disappointed. I also try to make sure that when he's off, I'm off, right? At least a couple of days. So if he's on fall break for a week, I'm going to take at least 2 or 3 days off just to spend some time with him so that he is not neglected. So I try to make sure I'm managing my time very thoroughly. I'm also not a very anxious or emotional person. Like some people, they sort of think all night, like, oh, I couldn't get any sleep last night. I am blessed to not be that person. Like I can do a major surgery and on the way home, eat a donut and get home, play with my son, and I'm not thinking about it.
You're an anomaly.
and I recognize that because some people are like, oh my God, that was such a hard case. Oh my God, this person almost hemorrhaged to death, all this stuff. So then they're just sitting there thinking about it, What's good is that? That's not going to do any good.
Now let me ask you something. As Miss Xavier back in the day, did you ever imagine that you would be the Dr. Plenty that you are today?
No, I mean, I didn't imagine I was even going to be Miss Xavier, right? Like I'm from the country. I'm from DeRidder. It's like 10,000 people there.
Where?
DeRidder, Louisiana. It's like on the border of Texas and Louisiana.
Okay.
There's like 10,000 people there. My dad went to college. He was the first in our family to go to college. My mom didn't go to college. My uncles went to the military. So I'm just sort of like this country girl, like going to this, university. I, didn't think I was even going to be Miss Xavier,
Yeah.
But you be yourself, you do what you want, you do what you want to do, you want to run for office. All right, let me run for office. And I will say that Xavier is probably the reason I am a doctor because Xavier is set up in such a way. That's a reason that they're number one in placing African Americans into medical school. Now, Dr. Carmichael, God rest his soul, was a doctor making machine, right? Mm. In my year, there were 105 of us that went to medical school. The number 2 school was Howard at that time, and it was only 36 of them that went to medical school, and they got their own medical school, right? So when you talk about Xavier, the year that I remember a couple years after that, they were still number one, but the numbers went down. I think it was only like 80 of them. We're like, I only got 80 people there. Because if you go and do what they tell you to do, there's no way you're not getting to medical school. They're like, you got to write your personal statement by the end of your freshman year. Nobody else is doing that. You have to apply for summer programs. Like if you're pre-med, they're like, what summer programs are you applying to? January, what summer programs are you applying to? and they have a list of summer programs that you apply to, and they ingrain in your mind that you are a failure if you do not apply for a summer program, because they're like, what you going to do, go work at McDonald's this week, in the summertime? What you going to do? You can go do research and make $5,000 or $6,000. Why would you work at McDonald's for minimum wage? So then everybody's like, okay, we got to get a research program. We got to get into research. And everybody did. Like, all my friends did summer research programs. And we did those every single summer. And we met with an advisor every single week that would go over our grades. So if your grades were slipping, they'd be like, you need to go to the tutoring center. You need to get your stuff together. It was very much so a very supportive place. I remember the power went out one night, and the next morning, I overslept, right? And one of my friends called in the room, because, everybody has cell phones back then. I had a cell phone, and I thought I was fly because I had a cell phone. But some of my friends didn't have cell phones, so they were borrowing my cell phone, right? And so I got called. They called the room phone, and because my phone didn't charge because the power went out, they called the room phone. And my friend said, hey, the professor said, they know you overslept. Get up and come to class. They were calling everybody, getting them up to come to biology lab. And so I jumped my clothes on. We went to class. And when I got there, we had started our experiments, but we were still calling our friends like, hey, the professor, you can come late, come to class. Nobody's going to do that at a PWI. They're not doing that. They're not making sure you're coming to class. They're not making sure you have an advisor. They're not telling you what to do. Hey, you need to do these summer programs. Hey, you need to turn in your CV. You need to turn in your personal statement. And I didn't do anything different. I literally did exactly what I was told to do. And everybody did. All my friends did. And we all doctors now.
Well, there is nothing. I got my undergrad degree from a PWI, but I did have an HBCU experience. I studied theater at Alabama State later, but absolutely nothing beats an HBCU experience. Nothing at all. And if you look like us, that's where you need to be.
Yeah.
Period, point blank, that's where you need to be. Nothing against, but if you want to become excellent, it starts there. And I truly believe
PWIs. It'll prepare you for, because I went to Tulane,
right,
and then went to Ole Miss, big time PWIs.
Yes,
but Xavier set you up in such a way that you know how you need to dress,
yes,
how you need to walk into a room. We had etiquette classes. That kind of stuff you don't get from a PWI. But they really were like, when you walk into this room, you need to look them in the eye. You need to shake their hand. You need to come dressed. If they don't tell you how to dress, you need to be business. They don't say dress, be business. And then the next day you can be business casual, but you come in their business. And it was, almost like your uncle talking to you when he talks about, and Carmichael would just straight curse you out.
That's what you need sometimes.
Straight curse. My freshman year, we were sitting there, and he said, y'all trying to act like little whores and going to parties, and your mama working 2 jobs to get you here. Don't make me call Lisa, and don't make me call. And we were looking like, how you know her mama name? How you know? They knew us, right? Class size is small. They knew us. And he said, don't y'all be clowning out there acting like those girls on the street.
I know he's proud and resting well, knowing that he did his job. What was your line name, and what number were you on your line?
Kayumi, and I was the ace, and Kayumi means strength in Swahili.
Oh, Kayumi. Okay, Kayumi. I'll have to look that up. And you were the ace. Okay.
I was the ace.
Okay. Miss Xavier being the ace. I hear you. Well, Nicole, it has been a absolute pleasure. I've heard your voice and I've seen your face, but to be able to greet you properly as my soror, and also to thank you for the work that you're doing, and more importantly, for making people feel comfortable talking about hard issues that we don't know if we're going to face, but we all face, and they make a difference with us building community and, realizing that we are all we need. So thank you so much for doing what you do. Last question, tell everybody how to reach out to you, how to catch you on the podcast when it drops, and how to, celebrate you like I will continue to do. And look, when I come to Atlanta,
come through. I got you.
I might not, I'm going to try to hit you before 72 hours to say, hey, what you doing? But
you know what? You're a soror. You can hit me up anytime. You can hit me up.
Thank you. That's all I need to know. Well, I'm coming really soon. So okay. I'm gonna try to link with you while I'm there, so I can at least hug and say, girl, what's up?
Yes. I would love that.
I'm right across the state line, so I'm not far. But it would be great to, to love on you, greet you, and, do our whole AKA thing when we see each other. Yeah. But yeah, tell everybody how to link with you, how to catch you, and how to support what you're doing.
Oh, well, thank you so much for having me. First of all, soror, this has been a fantastic conversation. I'm glad that we had it. Your listeners, I know that they're always amazed by everything that you're doing, and keep doing and promoting, everybody in Greekdom and everything that, and ways that we can support each other. People can follow me on Instagram. I'm on Instagram at pregnancy_pearls. If anybody ever has any questions about anything, you can email me at pregnancypearls@gmail.com.
Awesome sauce. Well, thank you so much. And you got to give me a pinky before. That's going to be a good screenshot right there. But Dr. Nicole Lee Plenty, Pregnancy Pearls podcast. And of course, you are doing wonderful things with maternal and fetal health. And we thank you so much. And that's a wrap for this episode of the Grown and Greek podcast. Of course, make sure you like, follow, subscribe, share, comment, and tell everybody about the podcast. And if you know someone of the D9 who's doing wonderful things and we want to share their story, please drop a DM to me at Grown and Greek Podcast on IG. Until next time. You can support Grown and Greek by subscribing to the podcast, shopping our exclusive luxury accessory line, or purchasing books from the D9 Book Club by visiting our website at grownandgreekpodcast.com. Don't forget to like, comment, and share on social media at Grown and Greek Podcast. Thanks for watching.